2019 webinar series. There will be more webinars taking place in the fall, and you will all receive email invitations to register for those in the coming months. Just a couple of quick housekeeping details before we get started. For everyone who is logged on, you should be seeing the opening slide of the presentation on your screen, and we will begin with the presentation momentarily. If you're having trouble hearing, please turn up your speakers or your headphones. The presentation will take roughly 35 to 45 minutes, and then we should have about 10 to 15 minutes for questions. If you look at the bottom right corner of your screen, you'll see a chat box. This is where you submit questions at any time during the presentation, and do our best for as many as you can. Also, if you're having issues at all with the webinar, you can use the chat box to let us know, and we'll do our best to help. A short survey will pop up on your screen. We'd like to ask you to please take a minute to complete the survey, because your feedback will help us improve our webinars in the future. I'm Joanne Sobey. I'm Executive Director of the RTO-ARO Foundation, and I'm very pleased to be here today with Dr. Paula Rochon. Dr. Rochon is Vice President of Research at Women's College Hospital. She's Professor of the Department of Medicine at the University of Toronto, and certainly last but not least is the RTO-ARO Chair in Geriatric Medicine. Dr. Rochon is with us today to highlight key strategies to improve drug prescribing for older adults, particularly those with advanced stage, chronic conditions, and use of multiple medications that make them vulnerable to adverse events. She will address the importance of optimizing drug therapy, why sex and gender matters to prescribing, and how recognizing and preventing prescribing cascades promotes health and wellness. Dr. Rochon, thank you for joining us today, and I will now turn the presentation over to you.
Well, thank you very much for the lovely introduction. It's nice to be here with you today. So, as you said, I'm going to be talking about improving prescribing strategies for older adults. And I think this is an incredibly important topic to talk about, in particular because of our population. You know, our population is aging, which means as people get older, it's likely that people will have more medical conditions. And when you develop additional medications, you often require and benefit from drug therapies that are being used to manage those conditions. But I think some of the things we're going to talk about is how do we actually think about optimizing the way we prescribe drug therapies. So sometimes, you know, when people have issues that develop, for example, somebody, if you can imagine, might develop a new medical condition. It could be something that is unexplained. It may be, for example, a little bit of swelling of their ankles. But we know that this is concerning for people. But what I'm going to talk about is maybe in some situations, that's a condition that maybe doesn't need to happen and could be made better by actually reducing medications. So we're going to start by looking a little bit about what got me interested in improving drug prescribing for older adults, a little bit about my story in terms of how I got to that point. And we'll also talk about something that I think is incredibly important, which is why sex and gender actually matters to drug prescribing. And I'm going to introduce you to a concept that we developed called the prescribing cascade, which is something that has got a fair bit of attention. So the kinds of things I'm going to talk about is a little bit about my inspiration. You know, how did I get interested in this area of geriatric medicine as a start, and then how did that eventually lead to my interest in the issue of drug prescribing? So this picture is a picture of what some of my inspiration was, which relates to my grandparents. And in particular, I'm illustrating here my grandfather. So you can see on the far left of the screen, my grandfather was quite young. And as I always remembered him, he was always a very active, energetic sort of person, a lot of vitality, and somebody who I really admired. But when he was quite old, he actually walked in a walkathon. So there's a picture of him walking because he did like to walk a lot. He was very active that way. He never really had a car, so he didn't drive, so he did a lot of walking. And at the top right, you'll see a picture of him when he actually completed a walkathon, which, if I'm reflecting back, must have been about 20 miles. And I recall he did it in just a sort of regular kind of street shoes, never had runners or anything like that, but walking was just something that he did. So I admired his energy. And also something that really resonated with me was that he lived to be over 100. He lived to almost 103. And there's a picture of me with him on his 102nd birthday. So being exposed to him and having the opportunity of growing up with a grandparent, and especially a grandparent who lived to over 100, certainly got me interested in aging and what we can do to promote health and wellness while we age. So how did I get there? So that was the first part. Yeah, you had to be kind of inspired and be interested and in this topic area, and I was. So after I got into medical school and I was looking at various things that I might want to pursue, I looked at a number of different specialties, and a lot of them were very interesting to start out. I did internal medicine, which is a general medical training. And after you finish that, you pick a subspecialty training area. And there's a lot of different subspecialties that you can consider. And I was thinking about a number of different specialties, and then became increasingly interested in the idea of geriatric medicine. And at that time, there weren't a lot of geriatricians, but I did have a couple that were role models that really inspired me to pursue geriatric medicine. So I did become a geriatrician, did some of my initial training in Toronto, and then got interested in learning more about geriatrics and realized that the United Kingdom was a great place to learn about how do you care for older people at a population level. They had a very interesting service delivery model and a lot of support for keeping people well in their homes. So I thought that was very interesting, and I went to the UK and learned about how geriatric medicine was conducted there. And it was there that I actually got interested in research. There were so many questions to be asked, but I didn't really have any particular research training. And so decided to apply for a program of training, a master's actually in public health at Harvard. I went there and started my training, got completely immersed in the idea of research. I guess I really fell in love with that whole area. I stayed there for another couple of years doing fellowship training, and then came back committed to doing work in geriatric medicine. So I've also spent, while I'm a scientist, I'm what you might call a clinician scientist. So I do both clinical work as well as research. So I spent quite a number of years in my doing clinical work with really frail older adults. And it was really those experiences that have taught or have led me to the research questions that I've asked. So what are you going to learn today as part of this presentation? So I hope you come away with a couple of things. So why optimizing drug therapy is something that's important, why sex and gender is something that matters in many ways, but it certainly matters to prescribing, and how recognizing and preventing prescribing cascades is something that can promote health and wellness. So let's start with what I saw with prescription drugs. So as I said, drug therapies are incredibly beneficial and very helpful. But what I've been learning is ways that we can make sure that we optimize the way that they work. So for me, this started back probably a number of years ago when I first started my clinical practice in an academic organization in Toronto. And in that setting, I was a geriatrician who was a consultant working with very frail older people and also seeing a lot of people who were in the long-term care home setting. And in geriatric medicine, one of the things that we learn is the idea that when you start a new drug therapy, you want to follow an approach that's called start low, go slow. It's kind of a common sense approach and a way to minimize drug side effects. And this is especially important if the drug you're starting is one that is not something that you have the time to be able to introduce. So it's not something that has to start immediately. So one of the things I noticed is that when I would be prescribing drug therapies for my patients, and especially when I was working in the long-term care setting, most of my patients would be quite old, and most of them were actually women. And so I would be prescribing doses that I thought were appropriate for those individuals. But I noticed that the doses that I was prescribing were not necessarily available. So say, for example, I wanted to prescribe a drug in a 1 milligram dose or a 2 milligram dose, but my patient actually really only needed a half a milligram or 1.5 milligrams, and that dose wasn't actually available. And I started wondering, was I a physician that was having this kind of experience, or was this something that goes beyond my initial experience? And I think this sort of illustrates where a lot of the research questions that I've done and the research questions that I think many researchers have, they come from observations that you make in things that you see, and in this case, things that I saw in clinical practice. So my question was, are these low doses actually available, and is it just me that's the person that's wanting to prescribe low doses? So this is, kind of like maybe a bit of a cycle of how it might work. So there's a clinical observation that leads to a research question. And as a researcher, you want to answer that question and obtain some new knowledge that might be helpful, not only for the patients that you're caring for, or I'm caring for, and the people around me, but potentially to create knowledge that can be used by people really widely, across the province, across the country, and internationally. Because I think, as you can imagine, a lot of the challenges associated with aging and the questions that we have are certainly relevant in Canada, but they're also relevant internationally. So this led to some work that I did related to pill splitting in long-term care. So I told you that I was seeing this on an individual level, but I did want to find out if it was something that was happening more broadly. So we did a study in a large long-term care home to see how often were patients actually getting a pill split for them. So interestingly, in this long-term care home, we found that about a third of residents were receiving one or more split pill each day. And the reason that most people were getting this split pill was because the low dose that was being prescribed wasn't manufactured. Now, there were some other reasons for this as well. Like, for example, maybe it was related to a formulary. There was only certain dosages that would be put on the formulary for different reasons. But the vast majority of reasons for the pill splitting was actually because that dose wasn't manufactured. And then pill splitting, as you can imagine, can be certainly time consuming, but it can also potentially have a problem in terms of benefit of the drug therapy, especially if you're not necessarily getting even amounts in terms of the dosages when you split the pill. It was also interesting that you needed somebody to actually split the pills. And in the long-term care home setting, it became apparent that it was actually a major role that somebody had to play in the pharmacy to split the pills for all of these different individuals who actually required that lower dose. So again, as I said, as a researcher, you ask questions and you're interested in things, and you start off with something small and you kind of you go bigger and bigger. So after looking, just not only in my own personal experience clinically, but then also looking across a large long-term care home, I also wondered, well, what about looking across the province? Is this something that is affecting people across the province as well? So in Ontario, from a research perspective, we have the opportunity to look at information from about 2 million people who are over the age of 65 living in our province. And the reason we're able to do this is because with our public health care system, we have health card numbers that become encrypted and allow us to pull together different data sources and therefore to answer potentially bigger questions. So we asked the question about how often drug therapies were needed to be split across the province of Ontario. So it's interesting, we took the example of just a common medication, frequently prescribed by older people, and this was a diuretic, a water pill. So this is, as I say, a very useful drug. But it was interesting at that time, and we did this a number of years ago, we found that across the province, more than a quarter of people were actually required to split the pills to get the dose that was actually being prescribed for them because that dose wasn't actually available. And interestingly, it looked like it was a bit more frequent in women. And the reason that the lower dose or that the splitting was happening was that it just wasn't manufactured. Now, the picture that you see on the screen, if you can imagine, is somebody sitting at their kitchen table with a cutting board and a knife cutting pills. And that's sort of how people are actually often have done this to sort of get the dose that they're being prescribed when they're in the community. And they also use devices like I showed in my previous slide, which are a pill splitting device that helps actually do this in a bit more of an automated fashion. But it does raise a couple of interesting questions. So clearly this issue we found meant that about more than 100,000 older adults were being dispensed this particular pill that we were interested in on any one day, and as I say, more than a quarter of them were actually getting a dose that was lower than was manufactured. So this is an issue that was actually relevant to tens of thousands of people across Ontario, and as I said, a little higher in women. So the question is, why is this happening, and why is this particularly impacting women? And this, again, started me on another kind of area of work that's resonated and something that I've continued to this day, which is asking the question about the issue related to sex and gender differences in health and healthcare, and something to look at, why things might be a little bit different between women and men, and if we know this information, how we can provide better care both to women and men. So this is how I started getting interested in the areas of drugs, certainly in the area of aging and geriatric medicine. And it's really become my life's work to examine these kinds of issues in the clinical and the research setting, and then to think about how this ultimately impacts health and wellness. Okay, so drug use in long-term care. So I think you've heard that this is a pretty frail population, and it's important to study because they do use a lot of different drug therapies for their medical conditions. And as we've said already, drugs are beneficial, but they sometimes can lead to side effects. And some of these are dose-related, and older women are the group that maybe is particularly important to think about because they do tend to use the most drug therapies, probably because they're more likely to have chronic conditions. I did mention this idea about sex and gender. You just think about it, and just about everything that we do, when you think about, the shoes that we're wearing, the kinds of clothes that we're wearing, how they're tailored, everything is done specifically to meet the needs of men and women. It does raise the question of how do we make sure that we're thinking about this in our healthcare as well, because it's certainly something that is relevant to a variety of different things. And perhaps, the issue that we talked about pill splitting and why women may be a bit more likely to have split pills may relate to the fact that maybe the appropriate dosage for women may be a little bit different than it might be for a man. Gender is also related to this, and this sort of speaks to more the societal components that might impact things like prescribing decisions, as an example. So, for example, when you think about little girls, you think about pink, and when you think about boys, you often think about blue. When you think about girls, you think about, in this particular illustration, they're talking about things like dolls and tea sets, whereas boys are more about action-type figures. So this does raise the question, which I think is really important, about the idea that one size doesn't fit all. So, the idea, if we're thinking about how we provide care and things that we're going to do, especially when we're thinking about older people, that we need to think about what we might do a little bit differently for women as opposed to men, so that we get the best information for both. So one of the pieces that has been a historical problem is that older adults, and women do represent the majority of older adults, are often not well represented in some of the clinical trials that are used to create the evidence that then goes on to be used, for example, to determine doses of drugs. So when older adults are included in these trials, it's also interesting that the information about women and men is often not reported separately, so you miss out on some valuable information. So drug trials, in theory, should include people that actually reflect the group who would eventually be prescribed the drug. And as I've said to you, that older people often do use a number of drug therapies, so it's really important that they're included, and men and women are both included well in these clinical trials, so we get the best kind of information. And this is something that is something that we're working on a lot to improve. And without this information, there's a health gap is something that happens, which may put women potentially at risk. So this health gap basically starts when there's underrepresentation of women, and particularly older women, in research. And it leads to things like drug prescriptions not necessarily being specifically tailored to the needs of women and men, and treatment programs that may be based on experience of either women or men, but not necessarily taking both perspectives or considering both perspectives. So some of this, there's a couple of examples in the drug world where this has had a big impact, and one relates to that's got a lot of press, is a story about ambien. This is a drug that's used for sleep. It's mostly used by women, and there's been some concerns about more side effects in women than in men. But it's interesting that this information about documenting the greater side effects in women and men didn't happen until the drug had actually been on the market for many years. And what they discovered was that the dosage for women was just a bit too high. And women, they found out, actually eliminated the drugs a little bit more slowly from their bodies than did men. And this impacted them in the morning. For example, they'd be a bit drowsier, and this might impact things like, for example, driving. And as a result of doing the studies that actually looked separately at women and men, they ended up recommending that there be a lower dose of this drug for women. So that's an example of where having this kind of information has actually led to a difference. So in terms of what some of the things that are being done to help us think about getting older adults included in research and making sure that we're getting information about women and men so we can do the very best job of making sure we have the best evidence to make sure that everyone's getting the absolutely best care possible. There's a lot of things that are being done. So working with community groups to encourage older adults to participate in research and to be part of that problem. And then to create, for example, clinical research units that are designed to ensure that older people are included in the programs. And then there's been work from a funding perspective, to make sure that we're thinking about things like sex and gender. So what have we learned here? So a couple of things that we've went through. So prescription drug use is common, especially among women. I introduced you to the idea of pill splitting, which is something that you might relate to, and the idea of importance of tailoring doses to women and men, and thinking about how side effects potentially can be dose-related, and that how we can make this better. So I'd like to talk a little bit about prescribing cascades and where that story started from. So again, it started from experience working with frail older people, and some of them in the community and some in long-term care. But a prescribing cascade is a really interesting concept because it begins when a drug side effect is misinterpreted as a new medical condition, and another drug is then prescribed to treat that medical condition. And so it's the idea of, it's just, to me, it's the image of a cascade, of something of a downward flow, and that you start out and things are going in a bit of a direction that is not necessarily desirable. So here it is, you get a drug, new medical condition, you get a new drug, and then that could lead to a further medical condition. And this is something that we saw in a couple of different ways, just by observing what might be happening in clinical practice. So one example might be that you start with a drug therapy and a new medical condition like Parkinson may develop. So people are looking a bit slower. And a new drug might be treated to treat that condition, which could lead to a further problem. So I guess the question is, why is this sort of thing not recognized? And it's often because if you give a drug and develop a new medical condition, and say it was you got a drug and developed a rash, people would make the connection pretty quickly. And as a result of that, you might think, okay, this is related to the drug. You go back to your doctor, you tell your doctor, and then they would discontinue the therapy and try something else. And this is something that usually happens in a pretty quick time frame. But when you're thinking about prescribing cascades, it doesn't quite happen like that. They're drugs that are often used on a long-term basis, and the side effects that we're seeing are things that might happen over weeks or months. And so they're also things that may not actually be thought of as being drug-related, and so that they could get missed. So here's an example. If you imagine this lady, we call her Mrs. A, and she had arthritis pain. So she describes the pain to her doctor. Her doctor gives her medication, a pain medicine, for that, which could be entirely appropriate. And the pain gets better. So that's good. She's feeling better. But a couple of months later, she returns for just a regular checkup with her doctor, and her blood pressure is taken. And there notes that it's a little bit higher than it was before. And a decision is made that maybe she should have a drug therapy to treat the high blood pressure. And so the question is that a problem? It's appropriate to treat blood pressure. And in theory, it's not necessarily a problem, but it might be. So for example, it could be what we call a prescribing cascade, because it's possible that the drug that she got for her pain might actually have contributed to elevating her blood pressure and leading to the use of the new drug therapy. So if you could imagine, if you went back and thought, okay, well, was that drug really needed for the arthritis pain, or was there something else that could have been done? Maybe it was a different medicine, maybe it was a lower dose of the medicine that was given originally, or maybe it was something like a physiotherapy, and maybe that medicine wasn't required. And if that was the case, you wouldn't end up with the high blood pressure or the need for the additional medicine. So it could be prevented. So this is a cartoon that just talks about the fact that, you know, sometimes we miss seeing these patterns, especially when things happen over long periods of time. And this is a cartoon that just illustrates, in fact, a prescribing cascade. You know, it says here, the white pill lowers my blood pressure but makes my legs swell, and the yellow pill lowers the swelling but causes another problem, and it goes on and on. So this illustrates this kind of issue. So one of the things we're interested in is, how do we go about preventing things like prescribing cascades? So issues around prevention, how do we get clinicians and patients to think about them more so that they're detected, and then what do you actually do to reverse them? So this has been something that we've been working on. And so it gets to questions that people can ask. You know, is a new therapy being prescribed, or is an over-the-counter therapy maybe being suggested as a result of prescribing cascades? And getting people really just to think about whether a drug side effect could be a potential cause of a new symptom or a condition. It may not be, but it's something that it's worth thinking about. And when we think about, you know, people are on a lot of different medications, and we want to think about, how do we potentially review medicines to determine if everything is still exactly right for that individual, or if there needs to be any changes into the medicines. Sometimes it's hard to think about where to start. And I think there's things that we can do to make that a bit better. So one of the ways that this can happen is to have medications reviewed. And this can be done often with a pharmacist, who are an absolutely excellent resource to use to have your medicines reviewed. Pharmacists often work directly with physicians. Often there might be a pharmacist working in the physician's office, and there's opportunities to meet with the pharmacist and with your provider, your physician, to review your medicines. It's also maybe important to think about different times when you might want to have your medicines reviewed. Might be when a new medicine is added, or it might be related to different kinds of transitions. Maybe when you're leaving a hospital, for example, that it's an opportunity to think about your medicines and whether there's opportunities to do any changes, like maybe changes in doses, or determine if everything you're on is still needed, or in some cases if things need to be added. So this is an image of a beautiful flower, a blue poppy, and it kind of illustrates, I think, the idea of when you're thinking about a topic, and when you get engaged in something like research, you start off with one idea, and it can lead to many, many different things. I love this image of a blue poppy because it was used in a book written by a friend named Bill Terry about the blue poppy, and it told about his experience of learning how to grow these poppies, which basically brought him around the world to learn about how other people have learned how to grow these plants that are actually pretty difficult to grow, and led to his ability to grow them really, really well, and then to teach other people about that. So I just love this image. So the work that we've done to prevent drug-related side effects is important, because it does help to improve overall health and well-being. And I think that's ultimately what we want to do, is make sure that people are as well as they possibly can be. Now, the work that I described about prescribing cascades sounds like it's fairly simplistic, but it does apply potentially to many different drugs, and it often applies to drug classes, which relates to groups of drugs. So the example that I told you about a pain medicine leading to elevated blood pressure, if you can imagine, there's many different kinds of pain medicines, and there's many different kinds of blood pressure medicines. So you have to think quite broadly in terms of how this might be having impact. Now, this concept of the prescribing cascade has caught, I think, the imagination of people around the world. And so people have been taking this, and it's been incorporated into different pieces of work that have all been designed to improve the way we prescribe for older people internationally. I think, as I said, aging and issues about promoting health in aging are things that impact everybody around the world. So as an example, this picture shows all the different countries where people have written about the prescribing cascade in the things that they've done. So for example, Australia, Indonesia, India, Belgium, the UK, and of course Canada, the United States, and then down into South America. So some of the things that people have done, so for example in the UK, they've created some really interesting concepts around polypharmacy, the idea about, people can be on a lot of different medicines, and in some cases it's entirely appropriate, but we're also concerned about when it might be a little bit inappropriate and where there's opportunities to do improvements, which is where our work comes in. And they talk about something called problematic polypharmacy, which is really about not being on the right drug combination for you. And one of the examples of that is medicines being prescribed to treat the side effects of other medicines, and where there are alternative solutions to reduce the number of medicines prescribed. And that's where the example of the prescribing cascade fits in that situation. In Australia, there's been a lot of work done around the concept of deprescribing, which is around decreasing doses in some cases, and also in other cases determining when it's appropriate to discontinue a drug therapy. And so what they talk about is simple things like having a list of your drugs, and then thinking about having the pharmacists and the physicians think about if this is the right combination in terms of the risk and benefit, but also thinking if any of the drugs that you're on could represent prescribing cascades, because then you want to take a more careful look. And there's also work happening in the United States where we're doing some work to design a potential study that can be used to think about how could we use electronic records to help look for combinations of prescribing that might require further assessment to determine again if the right doses or combinations of drugs are being used. So this could help look at this issue in larger groups. And we're doing a very interesting project right now that's exploring prescribing cascades that maybe are happening in different ways in different countries. So as I said, people around the world are all interested in aging and how to promote health and wellness with aging, and how to make sure that people are on the best combinations of drug therapy for them. And so we're working together internationally to think about how this would relate to different countries where they may have different prescribing type practices, and also exploring how it will be different for women and men in these countries as well. So we're working with people from Belgium, Canada, Ireland, Israel, Italy, and the United States. It's a fascinating project that we're looking forward to being able to share in the future. So to recap, I think we've talked here about prescribing cascades occurring when a drug side effect is misinterpreted as a new medical condition, and therefore another drug is prescribed that might not be needed. So the key to that is to prevent them really before they occur. So if you think about it and you're aware of these sorts of things, maybe you ask questions before another drug is started to make sure that they're potentially prevented. And then the idea of considering new signs and symptoms as possible results of drug treatment, and therefore you want to evaluate your drugs. And doing this sort of thing, preventing potential use of unnecessary drugs that might be causing problems, ultimately improves health and well-being, which is what everybody wants. And this gets to the idea of successful aging. And I think everyone is very interested in this concept, and I think nobody knows how to exactly capture successful aging. But it is a combination of things like avoiding disease and disability, about the idea of engagement with life and high cognitive and physical function. So it relates to a number of things and initiatives that the RTO is also doing. So what can you do to optimize your medicines? What are the things that you can do? So you can review your medicines. They're always to consider what other things can be done, and there might be some non-pharmacologic options. And there's the idea of decreasing doses or discontinuing them when they're no longer needed. And the idea of considering side effects as something that might be related to a prescribing cascade and how you might be able to address that. It's also important when we think about when people have new problems, often people go to drug therapy as one of the first options. But in fact, I think it's important to think that there are often other things that you might want to think about, like non-pharmacologic options, which are important. And these can be things like exercise, or it might be related to diet. Or there's a concept that's really interesting called social prescribing, which is something that's important and new. So social prescribing is something where a physician, for example, can refer an individual to a community resource where they might get some of the things that they need to improve health and well-being. This is something that is maybe particularly beneficial, might be helpful for situations where people want to get more engaged and want to have more opportunities for social interaction. And so this is where you write a script for a social prescription rather than for a drug. And this would then connect, where appropriate, to community resources and help individual engage and allows opportunities for participation. I think this is something that's getting a lot of interest. Other things that are important for prescribing is to keep a list of all your medications, and it's also really important to know why they were prescribed. I think this is something to emphasize because often medicines are prescribed and you're on them for very long periods of time, and it might not be clear what that original indication was. So it's important to keep that kind of information and to consider all the over-the-counter medications that people might be taking as well. It's not just the things that are prescribed. And when you do go to your physician, it's important to bring your medicines with you. Sometimes people use what's called a brown bag approach, so that you have them all in one place, and to make a point of regularly reviewing your medicines with the physician and the pharmacist. And when might be important times to think about reviewing your medicines? Maybe when you're being seen by, for example, it might be a specialist, you're going back to your family physician. It might be if you've had a recent hospitalization, or certainly around things like times of admission to long-term care. That's an opportunity to review medicines. Questions that patients can ask that might be important. Am I experiencing a symptom that could be related to a drug that I'm on? Is my new drug being prescribed to address a side effect from another drug therapy? Is there a safer drug, or could I be taking a lower dose? And then I guess a question that you always want to consider too is, do I really need this drug, or are there other options? Sometimes there may be other options, in other cases there are not. It's also important to think about keeping your medicines organized. So for example, there's some images here of people using dose sets, where you put your medicines and organize them in terms of the time of day for each day, so you know what you're supposed to take at various times. And there's also blister pack type options where that can be done for you, for example, at a pharmacy. these are ideas of ways that people can help keep their medicines organized, because it often takes a fair bit of organization to make sure that you're taking your medicines as they've been prescribed. So to recap on that, older adults are frequently using medicines to manage important chronic conditions. And it's important that we have the best evidence to inform the way to use these medicines. And so there's important work happening in this regard. And the idea that one size fits all is something that we're working on. Not specifically is the idea that clinical trials where this evidence comes from needs to make sure that they're reporting data in such a way that it can be used to optimize how drugs are used for both women and men. And the idea about how optimizing our ways that we prescribe drug therapy and thinking about things like prescribing cascades can be very helpful to promote health and wellness with aging, something that we all want to do. And just end with the idea that I think it's important to ask questions, get the facts, and understand why you've been prescribed your medicine. It's just important to be engaged in your health. And you are the person that often has or is in the best, in a very good position to be able to have this information to use it to your benefit. So thank you.
Great. Thank you very much, Dr. Rochon. That was really interesting. We do have a couple of questions. We have some time for that. So please do remember that you can use the chat box at the bottom right of your screen to submit any questions that you have. So Dr. Rochon, I'm just going to ask you if you will perhaps read the question and then respond to it.
So one of the questions relates, I guess, to emergency room medicine. And I guess the question is, there's a concern about emergency room medicine. And so maybe I think the question might relate a little bit to where people are getting their care. Certainly, a lot of people are encouraged, if you have a regular, non-urgent medical issue, to go to your primary care provider. Primary care providers are the ones that often know the very best about individuals, and so that's probably the best place where people should be going for their regular care. I mean, clearly, if there is what is considered to be an emergency, you do go to the emergency room, and that is where you should be for situations like that. So I guess in terms of being concerned about emergency room medicine, I guess I would be concerned if people are going there when it's for issues that really are better managed by their primary care provider. And so I think that's really important. And if you do go to emergency room, I think it's also important to make sure that you're connecting back to your primary care provider so that they know what's happened there. And that may relate to maybe a second part of the question, which is related to over-medicating. And I guess the concern here might be that if you go to an emergency room and you're seen by somebody who doesn't really necessarily know you, doesn't necessarily know your history quite as well, you could potentially get put on a medicine that may be something that should still be reviewed further. So I think this does raise the question. I think the point that we talked about is, when there's some sort of transition in care or something that's a little bit different, it's important to go back and review your medicine. So if a new medicine has been started, for example, that would be a great opportunity to go back and say, making sure this is the right medicine for you, and then looking at whether there needs to be other adjustments in your medicines as a result of the new medicine that has been started. So I guess this is an opportunity to go back and reevaluate the medicines at that point.
Okay. I have a couple of other questions for you, Dr. Rochon. You mentioned that dosages aren't always made appropriately, and pill splitting may be difficult. What should someone do if they can't find the exact dosage that they need?
So there's a couple of things that people can do. So I think first off, sort of at a big level, we're making sure now by having more older people included in clinical research and making sure that we have information about women and men, that this should guide the more appropriate doses being available in the first place. So I think that's one of the pieces that you need to think about. But still, there will be situations when people may be splitting their pills, and that might be, for example, when a medicine is being started, that might be something that's happening there. So in that case, in some cases, a pharmacy will do that for you, so you could potentially have them done and prepared that way. Or in some cases, people need to do it themselves, and there's things like pill splitters that can be helpful to people to get the best possible dose.
Another question. You explained that older women are not well represented in clinical trials. Also, I understand that in clinical trials, they usually use healthy adults, while many of these medications are going to be used for adults who already have pre-existing conditions. What can we do to change that so that clinical trials are considering women, particularly as well as those who already have some of the more common conditions such as hypertension?
That's a great question, and I think one that there's been a lot of progress made in. So I think that the first piece is just as you said, if you expect that a drug therapy is going to be used in a particular population, you've got to make sure you've studied that population. So especially when we think of, for example, older people and particularly women may be more likely to have chronic conditions, things like arthritis. They would be much more common in that group. So therefore, we need to make sure that we've included those people in the clinical research from the start. So I think that's sort of really fundamental. And then we've talked about how do you encourage people to make sure that they are willing to participate in trials, and how do you design the trials in ways that make it easier for people to participate. So how do you accommodate different schedules or different kinds of needs is really important. The other thing to think about is, when you're able to do research using population level data, you're able to look at how the drugs are actually used once they're on the market. So, and you actually are there able to see who actually is using these drug therapies and identify potential issues that maybe weren't identified earlier on. Like, for example, maybe side effects that hadn't been recognized that then you want to be more aware of, or maybe how they're used from a dose perspective that then can go back to inform how they'll be prescribed going forward. So lots of things that we can potentially do.
Great. Thank you so much, Dr. Rochon. I want to let you know how valuable it is to have you as our chair in geriatric medicine, and to be able to be with us to do these kinds of webinars and sharing your expertise. And I also want to thank everyone for joining us today. Before we end, please take a minute to complete the survey that's up on your screen right now, I think, or it will be very shortly. And in closing, I would like you to please consider visiting the RTO Foundation online and making a donation so that we can continue to fund important research, share knowledge, and raise awareness on issues that are affecting older adults. Thank you, everyone, for joining us today.